Hello, welcome to the session on Principles for Vaccine Risk Communication. Before we think about communicating about the safety of vaccines, let's reflect what are our experiences with communication about vaccines. We might have such experiences from various perspectives. If you are a healthcare professional or a vaccine safety expert, you might be confronted with questions from parents or young people about should I be vaccinated? You will have to give advice on the questions they raise. Think about it. Have you always been able to give the advice you wanted to give? Did you have all the answers to the questions asked? What did you think about the questions which were asked to you? But you just might have read about vaccines in the news. And maybe these news make you uncomfortable because they don't reflect what you think about vaccines and the safety. But maybe you were always astonished by the questions people raised in the media and you said, well, actually, they have valid questions. If you are a vaccinated person yourself, or you are a parent and carer, you might have very individual questions about the safety of vaccines, questions which might not be easily answered with statistics. You also may look at vaccines differently when you look at a completely public health perspective from a community standpoint, when you think about the health protection vaccine gives to the whole population. Or maybe you cannot be vaccinated, or your child cannot be vaccinated, or one of the patients you look after because of health reasons. Again, all of these things will change your perspective and how you communicate about vaccines, how you talk about them, what questions you ask, what answers you will give. The most important thing in communication is to understand that we will have multi-perspectives and that we will have to accept all the various viewpoints taken. There are no right or wrong concerns. Only we have to find the best answers and the best way to communicate about them. There are different levels of communication. There is the one-to-one level in healthcare or amongst individual people, and there is obviously the one-to-many level of communication. That is when an organization, for example, a learned society, a vaccination policy committee, a regulatory agency, pharmaceutical industry, or a journalist has to communicate to many people at any given time. Obviously, the requirements for communication will be different in these situations, and we will be able to less individualize information which has to be sent to many people at the same time. So the most important principles for any level of communication is that when we talk about vaccine safety, we want to have communication which is safe in itself, safe here used in the way that we should rely on robust evidence with regard to the assessment of vaccine safety, but that we should also rely on evidence from the communication sciences, which will tell us how to best effectively communicate. And then we will hopefully be able to use best communication practices. When we think about what we want to achieve with communication, we might come to different answers. Having clear objectives in communication is fundamental to being able to effectively communicate. If we say we communicate in order to inform, that might not just be enough. Normally, we talk to somebody because we want that the other person is doing something. Communication usually aims at a certain behavior. So when we think about communication objectives in vaccine communication, or specifically vaccine safety communication, what are the things we want to see? What is the behavior we want to see in others? Well, yes, we do give them advice for safe and effective use of specific products, but we want that this information is used for an informed choice in relation to immunization. one should consider what is my situation for or my child's situation, and then come to the best conclusion about yes, I want to vaccinate, or no, there is a reason for maybe I should not. We should also look that with the way how we communicate, we can create trust, trusted behavior of others, trusted in the sense of that they are trustful in taking this informed choice, and trust then in whatever happens afterwards, the vaccination, obviously. And this trust is obviously the trust vis-a-vis the regulation of vaccine that is adequately supervised and that the quality and the safety is guaranteed by these procedures. We also want to see a behavior which results in a vaccine uptake which is sufficient for health protection of the population. It is these objectives against which communication effectiveness would be evaluated. Now, let's come back to the specific points about the robust assessment of vaccine safety. For a very long time, we have looked at assessment as a process, an individual self-standing process, in terms of we gather evidence, we look at the evidence, and then we say, what is the evidence? But increasingly, we see that the assessment should be integrated with the communication process. Not only do we want to listen to the scientific data from studies or to the notifications of individually reported adverse reactions, but we also want to listen to the public concerns about vaccines so that in the assessment we have a scope broad enough that it also addresses the concerns and maybe the ideas people have about the causal pathways, that we can address that in the assessment. So our messaging will then be much better and be much more tailored to the population we are talking to, or the individual. In terms of communication-related evidence, what are we looking at here actually? This may be an area we are much less familiar with, since we are from the healthcare professional side and not from communication expertise. But communication-related evidence will look at questions like, who are our communication partners? What are their concerns and information needs? What are our partners' communication preferences in terms of style, tone, choice of words, the communication means? Is it talking? Is it writing? Is it a video? Is it through social media? What are the communication challenges given these concerns, information needs, and the preferences? And what are the challenges given what we know and what we don't know about the vaccine? We will always have to be honest about uncertainties, about answers we don't have. And what are the risk and success factors for effective communication? What could hinder that communication becomes effective? Or what are the points to help us to remember in order to communicate effectively? Well, there are a number of well-established principles in communication. Now, first of all, we should always address divergent communication needs. For example, in the influenza vaccine situation, it has been shown in studies that healthcare professionals were very frustrated that some of the authorities and public bodies gave out only very high-level information. They wanted to have many more details in the data to feel much more comfortable, to make their mind up and to talk about the vaccines. Now, other more general audiences, they have complained about the technical language which is used by public bodies. Communication science also tells us that we have to take into account what communication partners already know and believe. What we know and believe, and what we don't know, and what we know that we don't know, or what we don't know that we know, or that we don't know. All of this makes up a mental model in our mind about a certain topic. We know a little bit, We know that we don't know everything. We believe some things, we add it all, and it becomes a belief system in our heads. Now, if a new piece of information comes and that does somehow not fit in this model, our first reaction is to reject this piece of new information. So, as good communicators, it is our task to model that new piece of information in a way that it fits with with what people already know or what they actually don't know, and it has to be fitted. If we talk in a language which is very different from the mental model people have, it just doesn't fit. People cannot put this, they don't know basically where to put this piece of information in their head. So, understanding mental models is very, very important, and these can be researched. And that's what communication science essentially can help us with. Also, the method and content of communication should should reflect specific communication objectives, like the informed decision making and getting vaccination rates which are high enough for public health protection. So, we also need to be able to quantify risks based on the evidence and to express it properly. There are many ways to express risks. There are relative risks, absolute risk, attributable risks. They can be visualized, they can be put in tables, they can be expressed in percentages and natural frequencies. There are many, many ways to talk about risk. This risk quantification is important to understand, and different audiences have also different needs for how the risk should be expressed. Again, communication science has been helping us to research which risk quantification and expression creates the right understanding of the risk. And we have to be honest about uncertainties, I say that again. Only then we can establish trusted relationships. All of these well-established principles have already been formulated quite a while ago, namely in 1998, and you have the reference here of a publication. Examples for mental models. I would like to go more into this idea about mental models. Can you think about things you have heard about vaccines? For example, vaccines create antibodies. That is the mental model experts and healthcare professionals will have. And also many people in the public might know about this. Another mental model is that vaccines are not natural. Well, as a pure statement, that is also true. They're not natural. We've made them. As human beings, we have created vaccines. But what that could imply for some people, not natural, might create a heightened risk perception, which means you're sort of afraid something is not natural. Is it then good? Is it good enough? Is it safe? For other people, not natural is not such a big worry. Vaccine change viruses. I have to say that all these mental models here, all these sentences I found, I have not made them up myself. They do come from articles in the media and the social media, from blogs. So vaccine change viruses. Well, maybe they're not changing the virus as such, but they can change the strains. They can lead to strain replacement. So something is expressed maybe in a sort of vague way, but there is something in it. Vaccines give you less immunity than the natural disease. That is a very common mental model. Vaccines cause infertility. This mental model, or this fear, this concern, has jeopardized a number of vaccination programs in some regions of the world. And obviously scientists publish regularly studies recently, for example, for the HPV vaccine, which looked at the pregnancy outcomes after HPV vaccination. So looking at impact on reproduction is a very important topic in vaccine safety. Vaccines are not for pregnant women. Again, this is true for some vaccines and not for others. So when public health authorities communicated about the need for influenza vaccines for pregnant women, can you imagine how this did not fit in the mental model of many people who might have heard that medicines are not for pregnant women usually, or vaccines are not for pregnant women? Some people obviously don't know which vaccines are right and which are wrong, and they get scared. And if we don't explain precisely why this vaccine is good for pregnant women and is not like the other vaccines which are not good for pregnant women, people will not have the well, the appetite to take that risk because it doesn't fit in their mental model. There is a clash inside their perceptions. Another mental model can be vaccines give you the disease, but only a little bit. Now, in a way, again, that's in colloquial language. It's not so untrue from what happens. It's just that the vaccine mimics a disease. Um, but because mimicking a disease or giving a disease can be perceived as something, it makes you a little bit ill, it again can explain why people are, first of all, a little bit scared of vaccines. Now, I want now to look specifically on the one-to-many level of communication. It might be quite easy to listen to somebody you sit opposite to you, but how is it to listen to many people at population level? How can we do that? There are the ways of surveys, opinion polls. Surveys can be very high level and they can also be very detailed. They can involve interviews which go quite into depth. There are also methods from the media sciences. One can look at media coverages and analyze which kind of questions are discussed by the population concerned. A little bit less research type of method, but also more real time, could be to have a daily or weekly news and social media monitoring. You can analyze a lot from news and social media monitoring. There is the review of questions raised to health information services and authorities. Or we can look at how actually the vaccine coverage is and how they are used, by whom, who is a successful vaccinator in terms of do people prefer to go to have vaccination in the school programs or have vaccination by individual pediatricians and which kind of children who may be for example, asthma children, who vaccinates them more convincingly, so to say. All these issues could also be studied, and that will always give you more information about how communication, how the listening part of communication is well done. In terms of applying communication research reviews in practice, I would like to show you that actually looking at what gives the research from communication sciences can be really helpful. Here in this example, we have been looking in the European Union retrospectively what kind of research, communication science research, was available prior to the influenza pandemic of 2009 and 2010. We've done that after the influenza pandemic, but as a test case, so to say, with a cutoff point before the influenza pandemic, and we have looked if there was research done before which could have helped us communicating better in the influenza pandemic. And when I say us, I mean the European Medicines Agency, the place where I work. We have also done a lessons learned exercise after the pandemic, and in this pilot study we compared the lessons learned document with the communication research which was there before the pandemic, and we compared if there were some points already addressed in the communication research very early on. And in fact, yes, we were able to find a congruence in 3 areas. In the need for tailoring messages for different stakeholders, the need to address perception of preventable disease and related aspect, and the need to address concerns relating to specific vaccine target populations. Now, these are very high-level data I give you here. In fact, there were many details we found out which were very, very helpful. And we could then add these details to our guideline. In the European Union, we have a guideline on pharmacovigilance for vaccines, and this guideline has a quite extensive section now on safety communication or vaccine risk communication in the regulatory environment. That is new, because before we've never given such detailed guidance on this topic. I'm now showing you what are the principles we could extract from the communication sciences and how that has informed our guideline development process. Well, for the first time, we've really written down very, very clearly that the communication process should be integrated with risk assessment. This is something I've shown you in a visual presentation on slide number 7. And this idea of integration has now become part of a regulatory guidance. We've also defined our target audiences, and they are not only those whom we target with the vaccine or vaccinees, but also their parents, carers, healthcare professionals, health policymakers, and the general public. So this is obviously written from the perspective of a regulatory authority, and to some extent also from pharmaceutical industry, with whom we have to work together as a regulator to come to best communication strategies. Obviously, the communication strategies of the competent authorities are independent from pharmaceutical industry, but we do inform and work together, obviously, to make sure that information which comes out from various from the two stakeholders are consistent and aligned. Now, the principles underlying are really to think in terms of transparency and understandability. We want to be honest about the data we have, their assessment, and also the uncertainties. We want to present all of that in an understandable way. There is more to the guidance. We've also written down, and again, for the first time, that informed decision making and support to vaccination programs is the objective, that we also want to prevent anxiety-related reactions to vaccines. As we know, anxiety can trigger physical experiences post-vaccination, and we would like through communication to manage this proactively and hopefully to avoid. We also want to avoid vaccination errors and support precautions for use and warnings, so that the vaccines are actually used safely in these people who will most likely profit from the vaccine but not be harmed. We've made a number of precise given a number of precise advice on the contents of vaccines, so that a number of the benefit risk should be explained, not only the risk but also in the context of the benefit. And we have also to discuss about the risks not only with the vaccine but also for the risk with the what happens to somebody who's not vaccinated. What is the risk of that person? And what is the risk of decreasing vaccination coverage? I've seen in blogs that people make very good statistics, general citizens, parents, and they look at, for example, the frequency of measles vaccination-induced complications, and luckily this figure is very low. But even lower at the moment in Germany, it came from a German blog, the risk to catch measles is even lower because of the vaccination we have. But obviously, if many people don't vaccinate, then that risk of catching the disease will increase. And that is something people are not factoring in unless we talk about this. We also need to speak about the key functions of vaccine pharmacovigilance systems in order to create that trust of the population that we keep the vaccine safe by regularly checking that all information we receive doesn't reveal any risk we haven't been knowing about. In the guideline, the good pharmacovigilance practices in the EU, we've also we've also advised that a number of concepts should be explained when we use terms like coincidental event, temporal association. Um, a general a person of the general public will not know what temporal association is and that it means that it's temporal and potentially not causal. What is a single case? Uh, and when we say that we continue safety monitoring, how can that not be interpreted as we continue the safety monitoring because actually we have identified a risk? Very often in a regulatory authority, most of the time we actually monitor not because we have identified a risk, but because we want to check that there is in fact no risk. We want to see if there is something to identify. So, but that is not easy to make. To understand unless you know about pharmacovigilance. So it's our duty to actually explain these things. Further in the pharmacovigilance practice guidance, we have identified a number of frequent communication needs for the public. And these relate to excipients, residues, and special populations. And we also want to advise healthcare professionals on the management of vaccination and needle anxiety and concerns they may be confronted with from the persons they advise. For example, with regard to pregnancy, adolescents, immune sensitive conditions, or general anxiety, mood disorders, epilepsy. This is quite a novum to go into this level of details about the messages we want to give about vaccines. When we were creating this guidance, there was some questioning from experts saying, would that not be perceived as we believe there is a risk and that's why we communicate so extensively about it? But no, it's to say what we know and what we don't know, to be transparent, and that's what we want to do. It's also important for public health authorities and regulatory authorities also to keep stratified exposure and background rates for causal and coincidental events up to date, so that we have comparator data available when we look at spontaneously reported adverse reactions to vaccines. And we should really plan for communication. That is also important. Be prepared. Well, the last slide number 4 out of the 4 on the series of the EU good pharmacovigilance practices shows you some further high-level principles about the collaborative approach between the stakeholders, and that includes also the international partners like the World Health Organizations, that in the idea of planning for communication, this is part, collaboration is part of planning, but also more specifically like texts should be prepared and tested, and maybe some standard texts can be prepared proactively, so it's easier to draft public communication. We acknowledge in the guideline also the important role of the media in both ways. The media can help us a lot in disseminating our messages, but they can also be very critical and potentially change our messages or impact on that in a way we do not want. But again, the media overall have a very important role in terms of checks and balances of what happens in society and what happens from the side of authorities, and we have to acknowledge this in a very positive way. Media monitoring is one advice which has been given in the guideline. It's a tool which has not been yet used intensively for vaccines from the regulator side, but in the EU we are having had a pilot project and looks promising. So overall, we want to ensure that communication with the media is appropriate, timely, and meaningful. And then we also want to provide information on how decisions about vaccine safety or vaccination and not vaccination, but like the marketing authorization for vaccines has been reached. And how, from the regulatory side, the stakeholders in the regulatory world, what are their roles and responsibilities? So, in conclusion, what have we learned now in this session? We've been looking at that immunization, in fact, is not only a health intervention, but it is a population health intervention. And that means that, and because immunization happens in a societal context, this means that learning about communication from a one-to-many perspective is very important. It is crucial to understand the common perceptions in society, in the population, of individual vaccinees and also of the vaccines as products and the target diseases. Communication interventions at population level, for example, in form of the product information which comes along with the vaccine, but also in the context of immunization campaigns or regulatory safety news from regulatory authorities, have to take into account these perceptions which are prevalent in the public. And they should relate the information they provide to the concerns and information needs, and as well as the communication preferences of various subpopulations. We've learned from research that not only the news media, but health professionals, individual healthcare professionals, are most influential on the general perceptions and on the individual decision making as to whether to vaccinate or not. Parents will still very much rely on their pediatrician for advice. It is therefore very crucial to acknowledge the role of these influential parties and, as a regulatory authority, to support them with specific communication which addresses their questions and enable them to communicate with the potential vaccinees and the parents and carers. It is therefore important for us as regulatory authorities to learn from pediatricians what do you need to know. Overall, as a regulatory authority and also as a marketing authorization holder or vaccine manufacturer, we have to demonstrate the credibility in our systems that we are able to provide for the quality, the safety, and the efficacy of the vaccine products, that we show how we achieve this through robust and quality assured processes, and that we demonstrate this with transparency and communication so that the population can trust in the work we do and in the vaccines we provide them with. Many thanks for your attention.